Okay, Miss Iffy, we're getting going. All right. Well, good afternoon and welcome to the African Women's Cancer Awareness Association's virtual event. Your Girls Need You, Understanding Your Risk for Breast Cancer fundraising event supporting early detection and survivors coping during COVID-19. I'm Maureen Umeh, a board member of AWCAA. I'm also your host and moderator for today's virtual forum. It's a pleasure to be with you today. As some of you who may know me know that this is an organization that's near and dear to my heart. Anything I can do to help, I am always there at the ready. And I know that those of you tuning in, that you are vested in this as well. And we thank you so much for your ongoing support. I know it's not easy. Times are hard, but time and time again, we call on you and you answer that call, and you're always so very generous helping AWCAA and the mission to help the women and men that this organization serves. We thank you all for joining us this afternoon for what we hope will be an impactful discussion that raises your awareness about this terrible disease and helps guide us towards proper care and hopefully one day soon, a cure. Joining me this afternoon are some dynamic doctors who are experts in cancer treatment and research. Welcome Dr. Lori Wilson, a breast cancer survivor, a cancer surgeon and researcher who currently is the Division Chief of Surgical Oncology at Howard University Hospital. Dr. Wilson is also a physician scientist, well known for her work in translational research, community engagement, and health disparities. Her accolades, as you're hearing, are many. They do include awards for her humanitarian work, such as leading twice yearly medical missions to Africa. We welcome you, Dr. Wilson, and thank you so much for your participation.
Thank you for having me.
Absolutely. Our second esteemed panelist is Dr. Cedric McFadden. He is a colorectal and general surgeon, a speaker, a writer, a mentor. He teaches as an assistant professor for surgery and has nationally lectured hospitals, civic organizations, churches, and community groups. Dr. McFadden regularly appears as an on-air health expert on both television and radio. He's been featured on Dr. Oz, FoxNews.com, Essence Magazine, BlackDoctor.org, Shake Magazine, and that's just to name a few. He's a rock star in his field, and we thank you so much again for joining us today. We know your presence, along with Dr. Wilson's, is really going to make a difference. And our third panelist is Dr. Kelechi Uduhiri. She is a family practitioner, a family medicine physician. She's going to have something a little unique to our program later. she's ready later in the program. In addition to her work in medical work, she also is a creator of Success Coaching Academy and an independent sales director with Mary Kay Cosmetics. So that gives you a little hint of what she'll be doing with us this afternoon/evening. While the two previous doctors will talk about internal care, she's talking about external care. So we'll join her in a bit in the program. But Dr. Kelechi, we thank you for your time and for being here today.
Thank you.
Absolutely. So Dr. Wilson, I just wanted, let's talk about breast cancer as it relates directly to African-American women. African-American women of all ages disproportionately impacted by breast cancer. The CDC says breast cancer mortality is about 40% higher for African-American women in the US than for Caucasian women. And African-American women are often diagnosed with late-stage breast cancer when treatment options are now limited, they're costly, and then the prognosis is poor. My first question, Dr. Wilson, I'll direct it to you is, why are African-American women of all ages so impacted by breast cancer?
You know, one of the things that we still need to research and need more depth in the research is exactly why breast cancer is impactful in the way that it is. We know that when we look at large numbers of patients, we know that we see breast cancer younger in African-American women. We see that there are differences in the way that they're expressed on a cellular level. And we know that those differences sometimes limit treatment that expands the ability to give the best opportunity for outcomes. We see that there's still disparities. We see that there's differences in survival when we look at Black women and white women. A lot of that we used to think was just about economics, just about access, but we know that there are greater impacts that are called social determinants of health. So it is more than just access. It's more than just having health insurance. It's about the food security. It's about having safe homes, safe areas to access your care, to make sure that the teams are actually listening to what you're saying and have a very joint vision for what your care is. Using the best guidelines. There are guidelines that are utilized for cancer care from the National Comprehensive Cancer Network. And so making sure that all of these things are playing a role. What we know is that they have a different impact in our community. And so there are multiple things working together to have that disparity.
So you're talking about this from a physician standpoint, but you're also a breast cancer survivor. I want to understand, because you've seen it from both sides now. Tell us a little bit about your diagnosis and how your treatment has gone. Because I think a lot of people would say, well, she probably had the best care. Everyone was at her aim, gave her all the information she needed that she may not have had. So I want to understand, was that your experience, or did you not have that experience, and showing that really this is a problem for anyone and everyone?
I would have to say that I have had the experience over the last 7 years. I'm a 7-year survivor. And I have to say, when I began, it was difficult for me because my son was 1.5 years old. I originally breastfed, did all the things that we were supposed to do for health, all the things that are recommended. And what I found when I stopped breastfeeding is one of my breasts didn't go down. One of the things that I didn't expect was that I not only had breast cancer in my left breast, but I also had breast cancer in my right breast. I'm one of a few % of women who actually present at the same time with breast cancer in both breasts. Ultimately, I went through the gambit. I did chemotherapy. I did radiation. I did I did mastectomy on both sides with reconstruction and radiation. You talk about the moments that were not best moments during my care. I had a team that I absolutely trusted, but there was a difference in the way I was treated when my team members knew me and when my team members didn't. I have 3 experiences that I have to say were not optimal experiences and led to poor outcomes. I actually lost my reconstruction after talking to one of my providers, one who didn't know me. Didn't realize, and I think that you're absolutely right. Sometimes you do get better care because people are invested in who you are and they know who you are. But this person didn't happen to know. And I called and said, I just don't feel well. This was after my chemotherapy, my radiation. I was really tired, very fatigued. I was still working. And the person said, it's okay. I'll just call in some antibiotics for you. And, in the back of my mind, I was like, that's probably not the right thing to do. But I was like, I'm just going to trust that this will just work out. But before the weekend was over, this was on a Friday, before the weekend was over, I was actually admitted to the ICU with low blood pressure, sepsis, and I ended up having to have my reconstruction removed because I had a horrible chest wall infection. The second experience I had was another person who I think was trying to ground me in my diagnosis and told me within 20 minutes of knowing me that we would have to make a decision when I was going to stop my care. Oh, I know. And this was at one of the preeminent facilities in the country. And I was so taken off guard that I said nothing at the time and at the moment. And I can imagine that I have a voice, I have the opportunity. I said nothing at the moment. And so, yes, I've had those experiences, I'm sure, just like my patients, where I was so caught off guard by what they said that in the moment I had nothing to refute, nothing to say, that is so not fair. That is so horrible. Why would you say that to me?
I'm sorry, I want to bring in Dr. McFadden here because, you know, this is the problem here. Here's a doctor who's an expert in this field, and yet she's having this problem. For the regular patient, how in the world do they advocate for themselves when they don't have this level of experience? They don't have this voice. What do you say to that patient or that person?
Very, very hard question to answer. I often ask for patients to bring somebody with you. In the era of COVID, that's a little bit more challenging, but even just having a family member or friend over the telephone that you've already shared with before that appointment, they can be listening out, they can be a little bit more detached, and they can be ready to speak up and to challenge and really empower that person to have that with you. So that's one thing that we advocate for. I think the other bit is, as you said, recognizing that you have that voice and having that homework done before you go, having things written on a piece of paper that you bring with you is something that's tangible, that you can look at, that you can remind yourself, these are the things that are important. These are things that I need to have addressed before I leave today. And if you think that you're going to remember, when you hear news like this, you may forget that quickly. So having that piece of paper is just one thing that you can do on the spot to bring you back centered so you can remember to address the things and to stay focused on what you need to have answered.
But what are the questions that we should be asking doctors about breast cancer? And when should we be asking this question? Is it the initial visit? Is it the follow-up visit? And I know it's a complicated and multifaceted question, but what types of questions should we be asking these doctors when we go in, whether you've been diagnosed with it or this is your first time ever and you want to just see, hey, where am I and what should I be looking for?
So when I think it's important when women come with breast cancer. I agree with having someone there with you, having someone on the phone who will listen in. It is important to know, what is my diagnosis? Mm-hmm. It is important to know what are the words that I can write down and say that my diagnosis is invasive ductal carcinoma. My diagnosis is DCIS. So knowing the words. Mm-hmm. Secondly, what is my stage? Stage comes from three things: the tumor size, whether there's any nodes involved, and has it gone any place outside of the breast and the lymph nodes that are protecting it outside of the region. So lung, liver, bone, brain. You want to know what your stage is. You also want to hear that the person across from you is actually in the moment and listening to what you're saying, that they are actually understanding what your concerns are and answering the questions that you are asking, and not just kind of moving the discussion along without you, and not really trying to figure out, well, what are the things that are most important to me, so we can partner, so I can be as adherent as I need to be. So if I am a person who's well-resourced, has someone who can bring me to my visits, then that is something that is not as important. But if I am under-resourced in that I don't have transportation, I don't have someone who can bring me, I don't have someone who's my advocate, I need to know that as well, be a good physician for them. So maybe I can partner you with a patient navigator. Maybe we can get you those resources to get you to your appointments through resources that are available, because oftentimes you don't know those things until these sort of things happen.
And I want to pause because that's why we're doing this. AWCAA, this is what they do. And Lori, you know, because you're also on the board of AWCAA, and you know that this is so vitally important to have someone who can help you through this process when you're in this blur, this phase. You don't even know whether it's night or day, and you're trying to navigate this. AWCAA does this. I know we just popped up the link for donating, and I don't want to be beating you over the head with the donate button, but this is so important because really this organization does so much, so good. awcaa.org/donate is the site. Very easy. And listen, we are not asking for the bank here. Just any little bit helps, and it goes a long way. Ms. Iffy has been tremendous in making every little bit she gets work. I want to get it back to the discussion. Yes, indeed. Kudos to you. Thank you. Thank you. I want to bring the discussion back into Dr. McFadden. You know, Dr. Wilson was talking about a doctor that listens to you. When you have a doctor you don't feel listening to your team, how easy it is to switch. Because I think a lot of times we feel, well, they know best. I can't say anything. And even some advocates who you bring might say, well, that's the doctor. I'm not a physician. I don't know. So stick with it. Is it easy to say, I want a new team, or I want another expert to help me here? Because I know healthcare sometimes in this day and age can be challenging. So how easy is it for someone to really say, this isn't working for me, I need to go over here?
Well, I think first of all, you have to recognize that we have to keep you at the forefront. This is not about your doctor's ego. This is about what's best for you in all shapes. I have often told patients, if I am not the best surgeon for you, let me help you find the best surgeon for you, and whatever that means in my capabilities and what we can offer you in our relationship. So the first comment that I would have to that is understand that your doctor may expect that. The doctor may expect you to ask for a second opinion, and that's okay. And often, if you bring it up and the doctor really does act appalled to that, keep in that conversation that this is really about me making sure I fully understand what all of my options are. Because there may be options for you, whether it be with clinical trials, whether it be different procedures or techniques that they may not have access to. So you have to keep in the forefront, I'm looking at whatever's best for me. And I can't imagine there'd be one doctor that would take offense to that if you say, this is really about what's best for me and getting what I need out of this encounter with you today.
We'll be talking about treatment in just a bit, but I want to dial it back to first just knowing your risk for breast cancer. For someone like me, I don't have breast cancer in my family. I've done mammograms, but it is a real concern as I see people my age, sometimes even younger, who have been afflicted with breast cancer. I ask myself, what should I be doing different? Is it a diet change? Is it being more active? Is it just reading up on things? And I think that's, for a lot of us, those are the very basic questions that we have. And Dr. McFadden, I'll throw it to you first, and then Dr. Wilson, I want you to jump in after he's done. But what should someone like me, no history, I do what I'm told I'm supposed to do, the yearly mammograms, self-exams, is that enough?
Well, there are factors that we have control over and some that we don't have control over. You can't control over which family you were born into. You can't control their genetic history of medical problems. But you can control some of the lifestyle changes. Having a diet that's healthy, making sure you don't smoke, making sure you don't drink alcohol, making sure that you try your best not to be obese. Those are things we have direct control over. But there are other factors such as your reproductive history, your history of exposure to radiation that, again, may be outside of your complete control, but those are things that you can influence on a daily basis. Making sure that you're eating the right foods, that you're exercising, that you're moving. Those are things, again, that will reduce some of those risks. And then making sure you're having that relationship with your doctor, that you are getting those important tests that you mentioned before, that you're getting them when you need them and as frequently as you need to. And not only that, but you're getting the follow-up from those tests.
Right. Dr. Wilson, are there any warning signs that you would say people should look for?
Sure. I think it's important for us to make sure that we know our body. So knowing that the pendulum has sort of swung back and forth many times, what that really means, but really understanding what does your body look like, feel like, and so your breast and the skin, your nipples, everything about your body. If there is anything that is different and persistent, it is something that and persistent to me means 2 weeks. If there is
ask that
you notice that is different, you should take it to your doctor, your provider, because the vast majority of changes in the breast are not going to be cancer. So 8 out of 10 are not going to be cancer. It's those 2 out of 10 we don't want to miss. And it means that we want to make sure that we catch things early. We want to make sure that any changes are dealt with a good clinical exam, a good history and physical, and that any images that need to be done are done quickly and are very focused. That really gives the first foundation of kind of where you're supposed to be, and if anything else needs to happen. Just a couple of things I want to add about our discussion is that the vast majority of women do not have a family history. 75% of women do not have a family history. So the norm is not to have a family history. So that can't be an excuse for us not to do our prevention. And it's also important to know that though mammography, it may be uncomfortable, it is a way to save lives. And the reason why is because we want to do it every year. For Black women, we want to start at least at age 40, and then we want to do it every year for the prevention that we need to make sure that the breast cancer isn't missed.
So when I turned 40, I remember I had wanted a mammogram, and I was told, well, you don't have a history, so it's not that important. My doctor told me this, and I was concerned. And I would bet that there are people out there who probably have had the same message. And when you get something like that, but you feel, okay, I know that my risks are a little bit higher as a Black woman. You know, I'm not as active as I used to. I like to get my drink on every once in a while. And is this something I say, no, doctor, I want to have this mammogram, and should they be adhering to your wishes in that way? Or are there laws that say, no, you have to wait till something else happens?
There are many guidelines out there, and so there's mixed messaging, of course, but it's important that that the data push the reasons why we do things. The reasons why mammography at 50 might be a bad idea for Black women is by asking the question, so in the age 40 to 50, who has the highest mortality? Black women. And so if Black women have the highest mortality between age 40 and 50, why would I start my mammogram at age 50? It is about knowing the population you serve. It's about knowing the statistics that drive your population, and knowing that, yes, there is data out there that says that, especially the task force data, that said that you should start at 50, you should do it every other year. But that data had limited number of Black women in it. So if almost everyone was ethnically diverse, then I could get behind it, but they weren't. It was very homogenous, and it didn't reflect the population of patients that we're talking about. And when you look at that data says that 40 is probably your best. And actually there's some data out there that says we probably should start a little bit earlier than that, but that's more in clinical research. And we're working on figuring out that for especially Black women and Ashkenazi Jewish women.
So let's talk about treatment. And Dr. McFadden, I wanted to start with you on this. So there are so many treatments out there. You hear about clinical trials, you hear about, experimental medication. It's also dizzying. But then you also hear that Black women are disproportionately not included in these trials or getting these medications they need. Where do you even begin? Is it again something that you should be pushing for as a patient or an advocate, or where do you start when it comes to treatment and making sure that you're in the mix for whatever the best and the latest treatments are for breast cancer?
Well, I think it first starts with the diagnosis. Once you actually have an abnormality seen on imaging, you have to actually have a tissue sample that proves that exactly this is what's going on. Because what you don't want to do is have a whole treatment plan lined up, and there's no tissue sample or diagnosis that actually says this is the problem that we need to have addressed in this capacity. So once we have that tissue diagnosis, then we have to determine, okay, what's the best treatment option for you? And that may depend on the size of the tumor. It may depend on the size of the breast. For women who have small lesions and with a proportionate size, depending on the type of tumor, you could potentially do just a breast conservation therapy where you do just a single lumpectomy, and then you look at what's happening with the lymph nodes as well. But again, if you have a different type of a patient where perhaps just doing a lumpectomy will be quite deformative, you may offer the patient a mastectomy. That also may determine the patient's own preferences. There are some women that they hear the term breast cancer and they say, I want the mastectomy, and there's another channel there for a moment of education about, okay, what are the benefits of breast conservation versus mastectomy? I would love to hear Dr. Wilson's take on the use of mastectomy preferentially in African-American women who may prefer to have that as opposed to lumpectomy for the fear to get completely any potential risk of the breast out of the equation. And then that is followed by adjuvant therapy, or in some cases neoadjuvant therapy, depending on the characteristics of the tumor itself.
Dr. Wilson?
Yes. So when we think about making a diagnosis, I completely agree. Knowing what we're dealing with, ultimately using all our tools to find what stage we're dealing with, and then ultimately making sure we know the genetic and the molecular features of our breast cancer are also important. When we think about the options of lumpectomy and mastectomy, about 75% of women who come have what we call early stage breast cancers, those that are small or limited to the breast and can be removed with a sampling of the lymph nodes underneath the arm, and then ultimately will not need a mastectomy. However, about 25% of women, when they present, it might be because of the size, it might be because of the type, or it might be because of self-selection or ask that the women want to have mastectomy. And so it's important to know what are our endpoints. Endpoint is survival. Is survival different between women that have a lumpectomy and a woman who has the same disease but decides to have a mastectomy? Is she better off because she has a mastectomy? The answer is no. Her survival is no different. However, what is different is the potential for breast cancer to come back and what breast tissue is left behind. That means that the risk is probably about 14% or so if you keep your breast. If you have a mastectomy, one of the I think misnomers about that is that you think you go down to zero. Your risk never goes down to zero. It goes down to really low, about 2 to 4%, because underneath the skin where you separate the breast tissue from the fat layer and the skin, there are always going to be microscopic cells underneath there that are breast cells. And so they absolutely have the ability to transform in your lifetime. And so that means that you never go down to a risk of zero. Sometimes we see that in reasons why people do mastectomy, but it's untrue. The survival is the same. If you had the same woman who had a stage 2 breast cancer and decided that she wanted mastectomy, her survival would be no different. Ultimately, how long she would live and than if she decided to have a lumpectomy.
Oh, wow, I didn't know that. That's interesting information.
Yeah, and the reasons why oftentimes I think that we think that it's important that women have options. I am never going to take away the option of a woman to decide what she wants to do with her body. It's important, but it's important to have information. I am a big proponent of, even if you decide to have a mastectomy and you don't want to have a reconstruction, most reconstructions are done at the time of the mastectomy, that you don't want to have a reconstruction, I really, really advocate for patients to sit down with the plastic and reconstructive surgeon so they know exactly what they are expecting with the reconstruction. So if they decide not to do it, they are well informed. There's nothing better than a well-informed patient to know what it is that they need. And so then they can make decisions that are honestly decisions that are best for them. I told you a little bit about my story. I lost my reconstruction. I am not reconstructed. I decided with my husband that wasn't something that we needed to pursue. And so I am one of the women who are not reconstructed. And so I live a very happy, fulfilled life because I knew the options. I knew what the potential was and decided that for me, it wasn't something that I wanted to pursue. It's the same thing for every patient that we see. We want them to have good information and make good decisions for themselves.
And I think one of the pieces, if I can tag on to having any surgery, is knowing what those potential risks and complications could be. because when you're making that decision, that has to be discussed. It has to be discussed that you could potentially have the loss of that reconstruction. You have to talk about the problems you could have with swelling of the upper extremity after having the nodal dissection. You have to have the conversation about those longer term issues, because that then can also influence and impact that decision.
So I'd ask the question about clinical trials, because that's something I get asked about whenever I do, breast cancer stories, et cetera. Clinical trials, the fact that Black women are not represented in the numbers they should be in these trials. Speak to that, Dr. McFadden. What are these clinical trials? Are there numerous trials, just a couple? And why are we not seeing Black women participating in the numbers that we're hearing they should be participating in?
Well, it's not just, clinical trials for breast cancer. It's not just Black women. It's all Blacks. We don't participate in clinical trials, and we're having those conversations across all dynamics now. There's been several reasons for that, one of which is, we talk about social determinants of health and some of the healthcare disparities. A big reason why we don't participate is because in many cases, if there's not a person that looks like them on that clinical trials team, Black Americans are less likely to want to participate with those particular studies. So it goes into some of the outreach, the education of those populations, and making sure that, number one, that they're considered for those trials. Because we don't know if medications and things are going to be effective if we're not including the entire population that's going to be served by those medications. So that's very important to remember. But I think it also comes back to having that relationship with the doctor and that clinical team that's going to take the time to educate, because there's often so many misconceptions based on history. You hear about the Tuskegee experiments. You hear about, even the vaccines and what's being implanted in us. So I think we really have to have a robust and a very clear conversation about what this trial, what the limitations are, what are the benefits of it, and what it's not going to do for you. Because often it's a matter of just misinformation and basically societal influences or cultural influences that lead to the propagation of these negative effects.
Dr. Wilson, are there any current research going on, any current trials that look promising to you right now? I mean, I guess if you could talk about it in layman's term, because I know you're a researcher or you're obviously in the weeds with that, but is there anything on the horizon that's giving you hope right now?
I think that when we look at clinical trials, it should be important to know the numbers. Only about 3% of clinical trial members are Black. So it's important for us to know that representation matters, that having us in clinical trials. When we look at reasons why, the number one reason is oftentimes because we're not asked, and then we're not supported in a way that allows us to be successful. And clinical trials that I see that are coming down the pike is there's a clinical trial trying to determine whether 3D mammography versus 2D mammography is actually, 3D mammography is more effective than 2D. That's actually, I think, a really very important study, because the technology has been pushed towards 3D, but the data hasn't quite supported it yet. We believe, we extrapolate, we think that it's probably going to be better, but we don't know. And that's why it's important. And because Black women, for whatever reason, have more dense breast, it's important to have Black women represented in that study, because if we have more dense breast, then it probably is going to shape the data in a different way than some of the other ethnicities that are included in the study.
So is what I'm hearing that it's not necessarily that Black people are excluded. We need to do a better job of asking and participating.
No, we should not ask.
No, okay.
We should be asked. I don't want to put it ever on the patient's burden to think that we're responsible for not being included. It's their jobs to make sure that we're represented, And so, yes, as part of your armamentarium of questions, you always want to ask, are there any clinical trials that would be helpful for me? But I would hope that in everything that we bring, that my clinician is going to bring that, because it should just be a part of every discussion. It shouldn't be special, you know?
It should not be. And Dr. McFadden, you're nodding along like, yep.
Well, yeah, but the reality of it is sometimes you're not. Sometimes physicians, they're human, and they make assumptions about, oh, they probably wouldn't want to, or perhaps they don't have the means to travel back and forth. And there are assumptions that are made just off the cuff. And so I do think you have to have on that same piece of paper you're bringing, that needs to be one of those things that you ask before you leave that appointment is this an option for me? And to really hold their feet to the fire.
And I'm in agreement with that. I think that it is important for you to have your list and have those things answered. My real difficult soapbox issue is that it's always left on us to not be the ones who are non-compliant, to be the ones who are non-adherent, to be the ones that don't want to participate, when in actuality, it's the other way around. You know, if you explain it to me in a way that I feel the benefit, spend a little extra time with me, I'm likely to do what you need me to do. And
is this a discussion that happens in your field? Are doctors told, hey, listen, I just go to bedside manners, like ask them these questions? Like, it feels to me like this is like changing hearts and minds, which takes much longer. So at the end of the day, I know Dr. Wilson said you shouldn't have to ask, but it seems to me like you gotta ask, because you can't be sure the person treating you has the sensibility to be like, okay, I'm going to make sure they know about this, whether I think they can do it or not.
And so I am not saying you shouldn't ask, but I am putting the feet to the fire of the physicians and the clinicians who are out there, who are listening, and that are supporting patients who are predominantly Black in their practice. Right. That they should now, begin to, hopefully this can be a moment like, is this something that I do? Is this something that I bring to my patient? And how can I change if I don't?
So let me ask you this, Dr. McFadden, because you're our TV doctor here, right? And so you get to speak to a lot of people, and you get the word out. I'm wondering, from your perspective, someone like me, I'm on TV every day doing what I do. How can I be an ally in this and making sure that we're conveying this message? Or is it sort of, eating an elephant, you got to do it in small pieces? How can people like me be a better ally in helping patients or anyone get the treatment they need, and making people aware that you have to ask these questions, because yes, we too need to participate in this process?
Well, bringing this topic up before your viewers does a great wonder for them. And also, not only bringing the topic, but having people that look like those patients explaining it on television and in the media does wonders as well. Because, if you're like my grandmother, when you're flipping through the TV, you say, oh, look at that Black lady doctor. I mean, it just sort of, it connects in a different way. And having that commonality, having that language, that cultural appropriate language can often be effective at getting someone to say, you know what, I saw that doctor on television say, I need to do this. I'm going to remember to do that when I go back. But really bringing the stories up and having the people there from those communities to explain does wonders.
I want to keep you, Dr. McFadden, for just a second, because I want to switch gears a little bit and talk about colorectal cancer, which is your specialty. And the reason I'm bringing that up, because I didn't know a lot about it until obviously Chadwick Boseman passed away from colon cancer. Everyone thought, oh my gosh, so young. But I had a doctor on my show come on, and he gave some startling statistics about Black people and colorectal cancer, which I did not know in all of my years of living. I hadn't done a story on it. I just did not know. So you saying having someone who looks like you come on and explain it, I was riveted, because he was a Black doctor. And when he was speaking, I don't know if it was the emotion of having had the passing of Chadwick Boseman, but I was riveted and really taken by what he said, because he gave information that neither me nor my Black producer that particular day had ever heard. And we are certainly within the age range that we should be having colonoscopies, et cetera. So please talk a little bit about the risk for colorectal cancer. I know it's Breast Cancer Awareness Month, but we've got you here. This is your specialty. We would be remiss if we didn't talk about that with you here in our presence. So please just tell us a little bit about it and what the risks are for Black people.
Well, colorectal cancer is the second leading cause of cancer death. As many of these cancers go, it's one of those cancers, the sooner we find it, the better. And what's particularly encouraging about colon cancer is it is preventable. And that's the message that we get out, is that if we can find colon polyps, which are just tiny bumps, through a simple test such as a colonoscopy, it can be prevented. But as with many cancers, there is disparity. Blacks have a higher risk of getting colorectal cancer, and we have a higher risk of dying from colorectal cancer above all other types. And we also have the lower risk of being involved in some of the clinical trials. We also have perhaps a higher complication risk. And so it really comes down to knowing the fact that we own a lot of this, right? And these are great conversations to have, because it does encourage someone to get a simple test such as a colonoscopy. That's a very easy test, it's a 30-minute procedure that allows your doctor to find these polyps that can be removed so you don't have to have colon cancer. And if you do get colon cancer, it's not necessarily a death sentence. There are plenty of surgeries, especially if caught early, that can be quite curative. And even if it involves the lymph nodes, so it's more advanced, there's still a lot of treatment options available. That it doesn't necessarily mean that having colorectal cancer is a death sentence. So that should by no means make you fear and stay back from getting that diagnosis.
But with this particular cancer, I also heard that family history is very important, because Black people get diagnosed at a younger age for colorectal cancer than others. I don't know if I misheard that, but I believe that the age factor was something that struck me, that young people, young Blacks, can be diagnosed with colorectal cancer much more than say other ethnic groups.
Well, in 2017, the American Cancer Society changed their recommendations. They used to always remember the age of 50 for having colorectal cancer screenings, and they said, well, we'll change it to 45. Well, for as long as I've been sort of in training, I've had the conversations about Blacks should begin screening at age 45 because of that concern of having earlier, more advanced degrees of cancer diagnosed. Chadwick Boseman is one example, but he's not the only one. And so it is a concern that we're seeing more young people who don't have perhaps even family history, because again, just like breast cancer, having a family history is not 100% means you have colon cancer. In fact, most of the colon cancers that we see, there's no family history. In fact, only 1 out of 4 people with colon cancer have any family history for colon cancer. So again, it does raise the alarm, but it doesn't mean just because you have no family history, it doesn't mean that you're out of the woods.
Get those colonoscopies. I think that's the bottom line here. Get it, insist on it, go and get it. Dr. Wilson, I wanted to bring you back in. I heard you in agreement with the things he was saying. And I know, again, this is Breast Cancer Awareness Month, and the focus of this is breast cancer and knowing your risks. But, again, we would be remiss if we didn't talk about the other issues that we're facing here. I want to go back to you and your story. So with you being a specialist in this field, breast cancer, and then having breast cancer, how was it more difficult for you because you know all of the risks, or was it easier for you because you know all the risks? I'm curious. That's just something that occurred to me.
I think it was important. Our life experiences shape the things that, and oftentimes our choices. My mother actually was diagnosed with lung cancer when I was a 5th-year resident in general surgery. And I used to go home every weekend to take care of my mother because she staunchly wanted to stay home during her hospice time. And so I took the year off before my surgical oncology fellowship to take care of her. But what it taught me really in that experience was that what my mother needed was not a clinician. What she needed was a daughter. And so what I learned is that it's important to find the team that is the best team for you, that you trust, you're on the same wavelength, that they ask the right questions, you're on the same really trajectory. And then I had to turn it over to them. and believe that the care that I was receiving was optimal, so then I could be a patient. Because I knew that it's difficult for people who know you to treat you. I actually, in the very beginning, I had an experience with one of my very first MRI, where the technologist and I had sort of grown up together. She was a technologist in MRI, and I was a resident. And I remember when she started, she remembers when I started. And she couldn't look at me because I was crying. My first, I was in the MRI and I was crying. And so she really, that whole dynamic was very different than what the expectations for my emotional stability should have been at that moment. And that was just a reinforcement for me to know that I needed to be able to be anonymous enough to be able to take care of my emotional self, to be able to do the things that I needed to do, to ask the questions I needed to ask without managing everybody's feelings in the room. And so with that, I sort of realized that my husband was there. He was always with me. My team was an eclectic team. I actually went across country to Cedars-Sinai to have my mentor do my surgery. But everyone was the best. The guy who did my surgery was actually the guy who developed the sentinel node technique. And so,
what is that?
I'm sorry?
What is that? You said that this.
So the sentinel node technique for breast cancer and for other cancers is you no longer have to do a full removal of lymph nodes underneath the arm. You can, if there's no obvious evidence of breast of lymph node involvement underneath the arm, you can just sample between 1 and 4 lymph nodes out of the 20 or 30 that you have. And he developed the technology to understand that that was a way that we could preserve women from getting that enormous lymphedema or that enormous arm, and to protect women from some of the unnecessary surgeries that were being done. And so he developed that technique. And so when I had my surgery done, I had 3 lymph nodes that were removed out of my 30, as opposed to having 20 to 25 lymph nodes that might be done at other places.
And you said you've been in remission for 7 years. I'm wondering, COVID-19, how have you been coping with all of this new challenge that we're all coping with?
So I actually am still in treatment, and I have treatment about every 3 weeks. And my treatment is different because my husband can't come along with me. I can't have anybody there. And so it's really the relationships you build over time with the nurses and the staff that are there that, are always sort of looking out for you. But it is a deficiency in our healthcare system right now. My husband actually is in the hospital right now, and unfortunately my son can't go. So I have to stay home and believe that the care that he's receiving is going to be optimal for him. So, it is never easy, I think, in these enormously unusual times to undergo care.
Well, this family is praying for you and your family, hoping that everything goes well with you and your husband and that sweet child of yours. Dr. McFadden, I also want to ask you, the patients you're seeing during COVID-19, what are the challenges you've been seeing, and how have they been coping? Not just with their own battle, but now this whole new virus, this pandemic we're under.
Well, we've been having to manage fears and expectations. Fears about coming into the office, fears about having screening examinations, whether that be with mammography or even with colonoscopy, and letting people know that it's safe to have those things, and it's actually advisable that they do, because what we don't want to have in several years, increased numbers of cancers because we didn't find them soon enough. We didn't find the smaller pre-cancer areas soon enough. So managing those fears about, it's safe to come into the procedure rooms, it's safe to come into the office. And when they can't, there may be other options that we can consider. the beauty of colonoscopy is that, or colon screening is that, if a patient absolutely denies and refuses colonoscopy, there may be other things that we can offer them. And so, we've been having to manage that and also manage having patients not have their family members, because that's very key. I mean, we sometimes downplay the benefit of having our loved ones with us, but that is an integral part of someone's recovery. It's just that support. For us, being able to train that family if they go home with an ostomy of what this is going to be like. That's a lot of stuff that you really lose when the patient's family can't be there with them in the hospital. So we've been managing that, and fortunately, we've had a great team and we continue to do well with it, but it has been a challenge.
We are about wrapping up here with the section with you and Dr. Wilson, but I want to give you both one last word. Dr. Wilson, I guess to sum it up, what I've heard is, definitely do the testing, be an advocate for yourself, make sure that you bring someone with you, write those notes down, but to sum it up, again, I do know that in some instances, the system is stacked against you. I hate to be so blunt about that, but there are certain disparities that definitely put Black people at a disadvantage. But if you had to sum it up, someone listening out there or wants to pass a message along, what would you say about the importance of knowing your risk for breast cancer and being an advocate for yourself to make sure you get the best treatment and care possible?
I think it's key that you know your risk as well as your family's risk. At the next family reunion or the next family gathering, the Zoom meeting that you all have, make sure that somebody brings up, well, does anybody have a history of cancer that we should know about? That's information that should be shared because it has an impact on everyone in the family. I think it's also important that we realize that preventive things are important in our families. Prevention at a early age for both breast and, as we're talking, colorectal, that people are doing those things and realizing that hospitals are really going out of their way to make sure that they're safe environments for their care.
All right, Dr. McFadden.
I'd also like to mention, we talk about barriers, and while there are systemic barriers to us receiving care, some of those barriers perhaps are brought with us. So understanding some of those that we just bring in, such as our spiritual or our cultural influences that can make it harder for us to accept the care that is offered. We often rely on divine healing, or we often rely or negate the ability of the doctors to aid in that process. But we want to just bring all that to the table and understand that your doctor is a part of your team and we're part of your allyship and we're all here to help.
Well, I thank you both, Dr. Wilson and Dr. Cedric McFadden, for your time today, the information you've offered us. And I just want to circle back to what I talked about earlier with the donation, AWCA. This is what this organization is about. We're holding this forum, this discussion to give the information, but also let you know that we're here. And we make these programs possible by your donations. Every little bit helps right now. The donation link is there in the chat column. It is awca.org/donate. You can also just go to the website and donate. You've done so much. Those of you out there watching, you've done so much over the years, and we thank you from the bottom of our hearts. I know it's never easy to continue to donate, especially in these hard economic times, but we do thank you for your continued support. Tell a friend to tell a friend. We can use the help, and certainly we give back in a major way, as you've seen from this discussion and from those of you who've seen over the years that tune in and give your testimony of what can be done through this organization. Dr. McFadden from South Carolina, we thank you. We hope we see you again. We'll certainly be inviting you, so please take that call when I come knocking on your door or calling your phone.
Anytime.
Thank you so much. And Dr. Wilson, thank you. We're sending healing prayers your way for you and your family, and continue to do well. And you're always in our thoughts and prayers. We thank you both so much. And I would invite you to stick around if you'd like to. I know it's a busy Sunday, but we'd like to bring in our next guest now, who is Dr. Kelechi Uduhiri. She's a board certified family medicine physician, adding something a little unique to the program. As I said, there she is. She's been listening the whole time. We're glad you're still with us. Now, in addition to your medical work, you're also, as I said, a creator of the Success Coaching Academy and an independent sales director for Mary Kay Cosmetics, which is what you're doing today. You're talking about feeling good And not just from the inside, but from the outside, because they say what, when you feel good, you look good, and vice versa. So let's talk a little bit about before you show us the demonstration. I want to talk about what you're doing, because it is a whole scale approach to wellness here. So welcome to the program first and foremost, and I'll give you the floor for about 2 minutes. I'll ask you a question, and then we can do the demonstration. Can you hear me, Dr. Kelechi? Can you hear me?
Yes, I can hear you. Can you hear me?
Okay. We might be having Dr. Kelechi, can you hear me? There you are.
Yeah.
There you are. Okay, so I was talking about how you're saying when you look good, you feel good, and that's what you're about. So give me a little synopsis of what we're going to be doing this evening with you.
Absolutely. Thank you so much for having me. I'm really honored to be here. Thank you, Sister Ify. I call her Sister Ify, for having me. I've been a very huge advocate of AWCAA, and I really just enjoy this forum. And I want to also say to Dr. McFadden and Dr. Wilson, thank you for just empowering us with knowledge is so important. And Dr. Wilson's story was so riveting. So just want to thank my co-host for being here as well. My angle is as a family physician, as a mother, as a motivational speaker, and a wellness expert. I really believe in not just taking care of ourselves from the inside, but also on the outside. So during the day, I get to really take care of my patients on the inside, but I really believe for women, I try to empower them with wellness. And it is so important, what we're going through right now, that we take time for self-care. So what I bring to the table today is about self-care, because if we are not pouring into ourselves, we cannot take care of our family members, we cannot take care of our patients, we cannot take care of our friends and family. So we have to fill ourselves up so that we can give back. And only from our fullness can we really give back. So I'm a big proponent of self-care. And what more than a time such as this, right? There's so much anxiety, there's so much tension, there's so much fear, especially, to really take time out to take care of yourself.
So you brought some goodies that you're going to share with us.
Yes,
take care of ourselves.
There's a little bit of a delay. Okay, so as a family physician, as a preventive medicine doctor, like I said, I believe in wellness, and I also believe in entrepreneurship. So people always ask me, like, you're a doctor, what you doing, Mary Kay? You're a doctor, So, and that's like my number one question. And I tell them, well, I found myself very comfortable, and I knew that God did not call me to comfortable, and I said, what else? How else can I share of my gifts? And to me, it was entrepreneurship. And at that very time when I found myself comfortable and was asking myself, well, what next? I was doing medical missions. I was traveling with a team to Jamaica, to Haiti, Nigeria, Kenya, and we had orphanages in Haiti. We were just building schools and just, taking care of people in all manners of life. And I felt like I needed something else outside of my medicine that I could do to earn additional income to fund my mission work. And that's how AWCAA came across my path. Was, okay, this is great. This is great ministry. I can, I can do more, I can give more. And so for me, it was entrepreneurship. And as physicians, we're so, we're almost like siloed. We're almost boxed into what we do. So I believe that, I was not just called to healing in terms of treating and giving medicines, but also mental health and wellness and healing on the outside as well. So truly holistic approach.
Let me, I know there's a delay, but hopefully you can hear me. You have a question that says, hi, Dr. Kelechi. When are we going to do another beauty breast cancer event? I know COVID-19 has not been good for us all.
We're doing it virtually today. So that's what we're going to do today. So in the past, we've done it like in person. I came in and we taught about skincare. It's pretty much just teaching them skincare and how to take care of their skin. And then we had the lady who would do the wigs come in, and they would truly leave transformed. So it's been an amazing experience in the past, but right now we can still have that experience and we can do it virtually because, it is what it is. And we still have to learn how to take care of ourselves and take care of our skin.
All right, so let's dive in. I'm going to let you have the floor and I'll just read comments as they come in, but please, I know you've got a presentation, so don't mind me, do your thing. And
yeah,
with questions as they pop up.
All right. So what I love to do is I'm going to take all this off because I like to just show you the real deal. And it's just, so I'm going to start by using our oil-free eye makeup remover. And I want to share with you as I'm going through this, I found that Mary Kay for me was a platform because in my family, we have a lot of women with breast cancer. I have cousins and aunts who have passed from breast cancer. And I learned that Mary Kay donated millions of dollars. Mary Kay Foundation donated millions of dollars to research on cancers that affected women, as well as $3 million to domestic violence shelters. So those are big issues that were big to my heart. And if I was going to be part of any organization, it had to be in alignment with my my interests and my vision for women. So that is why I love what I do outside of clinical medicine. So I want to just share that with you as well. So basically, this is our all-free eye makeup remover. It's not only great for eye makeup, it's also great for all the makeup, okay? So I'm gonna use that to take care of my eye. And it's super gentle, it's oil-free, and it gets off eye makeup a lot. And not only for the eyes, but it can also take off all the makeup.
Are there certain chemicals that particularly people with breast cancer should avoid in their makeup?
Yeah, so that's why I'm actually going to show you this line, which is Mary Kay Naturally. It just came out about a year ago. And I love this. This is exactly what I'm going to demo today because it is EcoCert certified with natural products, right? So for women who are either, breastfeeding or pregnant or going through chemo, because it's 94 to 99% of natural origin, that is a line I would recommend for the skincare. Okay. It's free of SLES, SLS, parabens, and phthalates, which are chemicals that are used as preservatives in other skincare lines. So I love this because it's free of those chemicals. Okay. Can you see that? See how much it took off?
Yeah.
Like I'm keeping this on because this is my favorite color.
Keep the lipstick on.
Yes, I'm keeping, this is Poppy Please, and it's my favorite color. So that is staying on, okay? So this is the purifying cleanser. It is soothing with cornflower floral water, okay? So it's extremely soothing. It does not lather because it doesn't have those synthetic chemicals that cause lathering, which is the SLS and SLES. So I am gonna use a soft cotton ball. Actually, you can use, it's recommended to use just a soft cotton pad to apply it, okay? And this is, it smells like baby oil. It's extremely soothing, but what's in here is cornflower floral water and sweet almond oil. It smells amazing. It is, and it feels luxurious. And I have a treat. You can see right there, it's already getting off the makeup. Okay, and today I'm gonna use our Invigorate brush. It comes with a massage head and it comes with a brush head. And this is really great to just power up the clean. It's very, very soft bristles. And I use that along with the cleanser. Okay, so first step in cleansing is, of course, the cleanser to take off the surface dirt, okay? And with the brush, you're really increasing circulation, which is important for good skin health.
Do you do this every evening or twice a day?
This can stay in your bathroom. It's really fast. As I'm doing my thing, I'm taking this off. Super fast. So you can see how much more it got off. Amazing. So now I'm just going to use a little bit of water, some warm water here. Yeah, so cleansing is important twice a day, morning and night. You want to cleanse, right? Because in the morning, you're obviously starting your day. And in the evening, you want to take off any impurities, pollution, perspiration that you've gathered along the way.
Okay. I'm ashamed to say your skincare regimen so far is about 2 steps more than 2 or 3 steps more than I. My goodness, I can't even. I'm like, oh my gosh, I am way behind. It's soap and water for me, and I'm through.
Yes, but we're gonna upgrade you, darling.
Oh my goodness. I'm like, okay.
So that is just a cleanser, okay? The next step in skincare is really exfoliation, because exfoliation is going to take out the dead cells, okay? So it's really important. And this is our exfoliating powder. You can see the
Okay.
screen? Yes.
Yeah.
It's going to leave your skin feeling hydrated. Well, the powder is really more to exfoliate and get rid of dead cells. And it's got it's got our castor oil and citric acid, which is really good. Okay. It's very gentle. I actually sometimes just put it in the palm of my hand. Okay. And I mix it with a little bit of water.
Mhm.
Exfoliating is a very important part of your regimen. So you're going to have super easy. Okay.
How often should you exfoliate?
How often?
Mhm.
This is so gentle. You can do this every day. It is so gentle.
Wow.
You have several options for exfoliation. Okay. But with this powder, it is so, so gentle. I just mix with some water. I'm already in the shower. I keep everything in one place, so it's so easy for me to do it.
Mhm.
And I just take it off. So that's it. You don't need the brush. Just go ahead and take it off.
Wow. Okay.
Yeah. And of course, in the shower, it's going even faster than this, right? Because the water is running.
Right.
And I'm going to make sure my camera is visible. Okay, good. But, the reason you want to exfoliate because, our skin is changing every day, and you want to get, if you want dull, if you don't want dull looking skin, you want to exfoliate. Can you see how it's glowing already?
Hold up. Wait a minute. I need help here.
And this right here is so relaxing because I'm like,
tighten it up. Let's see.
Taking care of myself. Yep. So it's very gentle. This powder is extremely gentle.
Your skin looks amazing. I gotta give it to you. Your skin looks amazing. It really does. I mean, this is with no makeup on. I was gonna say you didn't even need to have the makeup on earlier.
No, right?
It's the regimen. It works. I love it. And I use there's different lines, but at the end of the weekend, if I just want something really light and relaxing and just soothing, it smells amazing. So the next step is our nourishing oil. Okay. So this is great for hydrating. So this is great for hydrating. It's using a few drops, just like that. It's super light. Okay. Sweet almond, olive oil, and sesame oil. That's what's in here. And it smells like heaven. Sweet almond, olive oil, and sesame oil. And this line is good for all skin types, but especially for women with sensitive skin. Okay. This is especially a great option. Or somebody who wants really natural products and doesn't want a lot of chemicals in their skincare. This is a great place to start.
I'm curious, do breast cancer patients, do they have issues with their skin when they're going through treatment?
It can be very dry, and I can certainly let Dr. Wilson add to that because she's experienced it herself. Skin can get very dry, right? The impacts of chemo and radiation on skin tone, on pigmentation. So it's really good to have a regimen that is nourishing and that is moisturizing. You want to nourish your skin and you want to moisturize, just to keep that healthy glow. And lastly, so we've done the cleansing, we've done the exfoliating, okay? We've done a little nourishing oil, okay? That's really the spa part of this treatment. And then lastly, we have our moisturizing stick. And I love this because it's a stick. It's made of beeswax, and you can literally just go straight onto the face to apply this, okay? Now, it's great if you have eczema prone skin, women going through treatments, like I said, get really dry skin. So that additional layer of moisturization is really, really good and healthy for the skin, okay?
Gorgeous.
Really simple. And it's just, you get this glow. Now, this line is not anti-aging. We have a line that's also anti-aging, but this is really great for women who want something simple, something natural, something quick and fast in the morning, okay? Ooh, it feels good.
I was gonna say, you look good. Wow, this is
amazing. If I can go back to the oil, you can use it in your cuticles as well as in your hair. Okay, so it's really good for that. It has multifaceted purposes. And then lastly, I love this eye patch. We have this Hydrogel Eye Patches. Okay, I'm in front of the screen all day on Zoom calls and all kinds of meetings. And this is great for that to soothe the puffiness around the eye
Oh,
area.
yeah.
Okay. Tired eyes, puffy eyes, circles. This is really good. And it's basically hydrogel. So I'm gonna pull it out. There's like 30 pairs in here, and it looks like that.
Okay.
And it has an amazing cooling effect. So this tip right here goes in the corner, and it's really cool and just it's a zen moment right now.
And how long do you keep that on?
This can be on for 20 to 30 minutes.
Okay. Yeah,
Yes,
you can really see it, at least with my camera. I can't even see it. It looks like it just
exactly,
blends
just
right-
disappears. Yeah, this is an eye treatment, and I like to use this at the end of my skincare routine. Just give myself a little eye treatment, cool the eye area. In the interest of time, I'm gonna take it off, but I wanted to add that little treat.
Okay,
Good, and that's it.
that's
And
it.
then you take it off. I'm just gonna pat it in. And it's one time use only. You don't reapply this.
Okay,
And then you just take it off like that.
there you go. Voila.
And just kind of like blend the little juices in. Okay. And we're busy. I'm busy. Got things to do. Got to go. Okay. So I'm gonna give a quick dash out the door look. Okay. Now we have the cleansing, right? Then we have the gentle exfoliation. Then we had hydration and moisture, right? And then the last step in regimen is really light coverage. It can be with foundation or CC cream. Okay. Because that is protection. What I just put on right now is a little bit of a primer. Okay, it's good to prime the skin before you put color. And I know right now people may not be wearing a lot of color, but we still have to look good for our Zoom meetings, right? And the
But
light,
only from, but with the mask on, only from here up.
right? And if you're outside, only from here up, right? So
Right, right.
yes, what I love is you can still do very gentle coverage with a CC cream, which is like that. I like to put it in my cream to powder. We have this cream to powder. It's a cream to powder foundation, and it's so easy because it's cream and powder mixed in. Cream and powder mixed in gives you a quick powdery finish to your
Yeah,
regimen.
it's pretty fast.
And the key thing is skincare. When you take care of your skin, your makeup is gonna look flawless. So I really focus on skincare, because we have to be with our face for the rest of our lives.
Yeah.
And it's really important to take care of our skin. When I was doing the eye patch, the reason I do that is because the eye area is the first area we see the signs of aging, right? Would you agree? It's the eye area. So the eye patch really helps minimize the appearance of wrinkles, especially if you use our anti-aging line. We have a special eye creams for the eye area, but the eye area is really important to take care of. And this is just a quick dash out the door look, just a little bit of cream to powder foundation, quick powder. That's it.
That's it.
Yep. If you want, you can do a dash. And this is what I do for my ladies pre-COVID. So I cannot wait for us to get back in person so we can have this much fun, right? But for now, we'll do it online, ladies. We'll do it online. Quick eye color, just a little powder, little eye shade on my eyes there, really fast. I have a mirror right here, little mirror right here. Use that, like that. Most important thing is skincare. But quick dash out the door look, little mascara. This is a Lash Love Panorama. Quickly. That's it.
That's it. You did it.
We're done. And I'm gonna just touch up my little lipstick again with my
Your
Copy.
favorite color.
That's it. All right. Voila.
There you go. There you go.
I love it.
I think you look beautiful without the makeup. I didn't even think you needed to reapply, but I think it goes to what you're saying.
Thank you.
Pampering yourself and just making yourself feel good, look good. You know, it all plays into your psyche and your treatments. I think it's important that we cover this space as well.
Absolutely. Self-care is really important. You know, who are you talking to? Who are you connecting with? You know, reach out, you know, because it's really important right now that we stay connected. Right now, we're very disconnected. But it's really important to take care of yourself. And what I'm doing today is all the ladies who are here, participants, they're going to get a complete set as a gift from me for self-care. So make sure, ladies, you let Miss Iffy know your address, and I can ship this out to you first thing Monday morning. So they all get a free set. And anybody who wants to, because this is fundraising, right? So if they go to my website and order the Mary Kay Naturally or any skincare set from now to the end of the month, all profits go to AWCAA.
Yay! That's amazing. Thank you.
Yes.
Wow.
Yes.
So next Zoom event we do, nobody's gonna be wearing makeup. We're all just gonna be like, look at our glowing skins, right?
Yes. I mean, this is it's clinically tested for irritancy, and it's non-comedogenic, so it won't clog your pores. It's a really great start for the woman who's not sure, but they want to start with really taking care of their skin. It's a really great place to start. So I hope you enjoyed the presentation.
What's your website for anyone else who wants to, what's your website?
It's marykay.com/Dr. K, DRK, marykay.com /DRK. Very simple.
I love it. Thank you so much, Dr. K. This was fun.
Yes,
we hope to see you
again soon.
Once we can all join each other in person. We hope to do this as we had been in years past. But thank you so much. Miss Iffy, I see you there. You've been with us the whole time. I'm going to open the floor to you. I knew the program may run a little shorter, but it's fine. We got the information in there. I want to open the floor to you to say a few words before we close it out. But before I do that, again, awcaa.org/donate. Tell a friend, tell a neighbor, tell the garbage man. We don't care. Everybody.
Tell everybody.
Ms. Iffy, I open the floor to you.
Oh, wow. I just want to thank everybody for being so gracious to spend time with us this evening. I especially thank my mentor, my board member, Dr. Laurie Wilson. This lady has been to Africa with me twice. So please, we all pray for her and her family.
Thank you.
Yeah.
I want to go.
No problem. I think even though her time is up, I personally would like to let her know that she looks good with her makeup. You're an inspiration to everybody.
Yes.
And I hope Dr. K sold you on her makeup today. So maybe you can join her makeup line. But Dr. McFadden, we really, really appreciate you being with us. As a Black woman, I had a question. Do our diets have anything to do with colon cancer? Or, I mean, what's your best advice on our diet? I've heard eating a lot of red meat, but I'm sure there are other things that we can eat in moderation or avoid completely. So since you're still here, I'm glad you're here. Can we learn more?
Yes, and I'd like to say I'm expecting to get my Mary Kay cosmetic gift set in the mail too. I'm kidding.
I got you. We got a men's line. I got you.
Okay. But in all seriousness, you know, diet is important. You mentioned red meat. Diets that are high in red meat can be a risk factor for colorectal cancer. Diets that are full of the fruit, the vegetables, the whole grains, that's definitely the way to go. I'm a big advocate of a plant-based diet, but if you are eating meat, you want to eat it in moderation. You don't want to be having a piece of steak once a week. You want to eat that very sparingly. And also obesity based on our diets can also raise our risk factor for not just colorectal cancer, but also breast cancer. So keeping diets that are low in sugar, diets that are low in fat, you know, eating all the good stuff that your mom told you to eat, it really comes back to it that it's really not very complicated, but you know, it really is having those basic fundamental things in the diet and keeping that body weight as normal, close to normal as possible.
Can the effects of can you reverse, if you're on track, let's say if you're, you know, I'm equating it's like pre-diabetic, are there things you could do to reverse the effects of, say, you're trending towards perhaps a cancer? Are there things you could do to reverse it if you start living a better lifestyle? I don't know if that question makes sense, but I'm wondering. Talked about diet and lifestyle and exercise. If you stopped, if you were suddenly, if you find yourself on the track to perhaps you know, being diagnosed with some sort of cancer, or you had all the telltale signs, could you reverse that?
So you can certainly help that cause. I mean, we see it all the time with, you know, lung cancer. You know, for people who smoked for years, it's never too late to quit smoking because there's still potentially some benefit in smoking cessation. It's not 100%. It's not like you can completely reverse all those years, but it certainly can help. And so every bit helps in that instance, yes.
Okay. All right.
So
no,
I do have a breast cancer survivor who said she would like to let us know how COVID-19 has affected her. However, she doesn't want to show on camera, but we'll still like to hear from her.
Okay.
So Miss Irene Asiama, if you're there, can you unmute yourself and let's hear you?
Yes.
Okay.
Hello, everybody.
Hi.
Well, I'll say as a survivor, not just a cancer survivor, but the chemo also enlarged my heart. So I have a heart issue to deal with. I have a pacemaker. So during this COVID-19, I have 4 children and I have 3 college students. So I have to be very, very careful with them. And I from the beginning, from the onset, I sat down with them and I said, you know, your mom is high risk. So be careful. It's not just you going out and coming in, but whatever you bring in, you might give it to me and I might, you know, be, it will be a problem for me. So I'm being very, very careful. I don't go anywhere without my mask, even in my neighborhood. So during the COVID-19, I had a lot of time on my hands. So I'll go for a walk twice a day. So I'll do morning, I'll do evening. So I'll do about maybe 2 hours a day. But I had my mask with me. So even my neighbors, you know, when the chit chat, I'll put on my mask and they look at me like I'm a little weird, but I have to protect myself. So in the midst of all this, and I know to build my immune system, because I know Ms. Ify just asked the question about diet. I know our diet makes a big, big difference. And one thing that I was blessed with, I've been a cancer survivor for the past 12 years. I kind of changed my diet. So even with the African meal, you know, there are substitutes that instead of eating the banku and the fufu, I'm making them out of cauliflower. I'm making my fufu out of broccoli. I'm learning to change my eating habit. And, you know, I wake up in the morning, I make a smoothie out of dandelion, watercress, berries, ginger, And we know with the COVID-19, most of Africans we know about the hot water inhalation. Every time I go out and come in, I'll do that. And I'll use sometimes eucalyptus oil or, any, just sometimes plain hot water, just inhale it. And I'll drink my ginger and my garlic, and I make a paste out of ginger, garlic, and lemon, and add apple cider vinegar to it. And I'll drink that twice a day. So as a cancer patient and as a survivor, we are Irish, so we have to take extra precaution of our diet and our way of our lifestyle and the way we take care of ourselves, and so we can live longer and just survive this COVID.
Thank you so very much. I think I'll hand it back to Miss Maureen. We are truly grateful. I had 2 other cancer survivors, but apparently they are shy on coming on. So
Okay.
I don't know what else to say.
That's okay. We thank them for being here. I know sometimes, you think you want to talk, then sometimes the courage leaves you in the last minute. It's okay. We understand we're all family here. Again, thank you all for logging in and for listening and always being so ready to support us in whatever we do. For the survivors there, keep on surviving, keep on thriving. We are behind you every step of the way. Hopefully you've learned, for those of you who are not, you've learned how to be an ally, a better ally. You've learned what questions to ask for yourself. When you go to have your checkups, I know I have, we will introduce you to colorectal cancer, which is something we all need to be cognizant of. So please take heed of that. Tell someone in your life, a loved one, that they too need to be checked. Let's take care of each other. I think that's the best way we can do it, especially this time. We're learning, we're all connected. We're all connected, and we need to care for each other and take care of each other. And through groups like this, it's even more poignant that we see that when we see that. Thank you, Dr. Lori Wilson, Dr. Cedric McFadden. Thank you, Dr. Kate. We thank you for beautifying this discussion and us. You brought some much needed levity to the situation, and we appreciate it. We don't always want to be heavy. Life is about living and being joyful. And when you're happy, I believe that really just encompasses everything around you and internally makes you feel good as well. So thank you all so much for your time this Sunday. I'll leave you again with my call. Please, please, please donate even long after this chat is over. AWCAA is right here in the Maryland area. The website is there, .org, awcaa.org. Log on, donate. You don't have to give us $1 million. $1 helps. Every bit of it goes a long way, and it's tax deductible. So I'll leave you with that. And again, thank you all so much. God bless you. We appreciate you. And we'll see you next time. Good night.
Janet, are you there? Hello, Miss Janet.
Yes, I'm here.
Yeah, come on now. We're signing off. I just saw your notes that you're on.
I have been here the whole time.
Okay, let's hear from you. Ms. Janet is one of our breast cancer survivors, and so I think she also would like to put in a few words to cancer survivors out there.
Absolutely.
How she's surviving through this COVID. So it's all yours, Ms. Janet.
Okay, hi everybody. I am, this is my 3rd year. December would be 3 years since I had my surgery, and I have had a few reconstructions, so I heard about that. In fact, I even had one this past June, and I made up my mind I wasn't doing any more. I have decided not to. I'm living through COVID, teaching from home, but about to go back to school, which I'm not looking forward to. So I'm a teacher in DC, and they're about to send us, the elementary teachers, back to school. So God has been good to me. Life has been good to me because I have people all around me, and I have been very particular in where I go or what I do during this whole COVID time. So Thank you to the good doctors. I learned a whole lot again today. I learned about colorectal cancer, so I'll take that into perspective and know what to do with myself. But as a cancer survivor, I'm thankful every day, and I make sure I preach it out to everybody. I'm not shy to say it, and I'm not shy to tell people, take care of yourselves, check yourselves. Thank you.
Thank you so much. Okay, I think now we can close. But thank you, everybody.
Thank you, guys. Have a great evening.
Thank
Have
you.
a great week. God bless
Thank
you.
you. Thank you.
Thank you,
you.
Dr.
Bye-bye.
McFadden.
Bye. Thank you. Thank you so much.
Okay.
Bye-bye.
Thank you.
Thank you.